morning everyone. So starting with the first case for the day. Now a 27-year-old lady who was born to parents of a second degree consanguineous marriage. She presented at the age of 2.5 years with complaints of recurrent vomiting, dehydration and failure to thrive. On examination, her blood pressure was 90 by 60 millimeters of mercury. She had clitoromegaly and there was no hyperpigmentation. Lab showed sodium of 135 and potassium of 5.5 millimoles per liter. Her 17-hydroxyprogesterone was 630 nanogram per milliliter. DHEAS was 21 microgram per deciliter and her plasma renin was 9.9 micro international unit per ml. So based on the clinical profile and lab parameters, the diagnosis of congenital adrenal hyperplasia, salt wasting phenotype due to 21 hydroxylase deficiency was made. She was started on hydrocortisone and fludrocortisone and she underwent clitoral reduction surgery at the age of 7 years. She attained puberty at 11.5 years and she attained adult height of 154 centimeter. Her mid-parental height was 152, so she achieved her genetic potential. She got married and she was counseled for the genetic screening for the partner. However, it so happened that the husband was in armed forces and he was posted in a distant place, so he was not able to come for the same. Now she is coming to us at 6 weeks of pregnancy and currently she is on hydrocortisone 10 milligram in the morning and 5 in the afternoon, and she is also on fludrocortisone 10 microgram once daily. So stopping at this point, what is our main concern at this point of time? So as rightly mentioned by our colleague, because CAH is autosomal recessive disorder, there is a risk of inheritance in the progeny based on the genotyping of the partner, which is not known in the present case. So our main thing was what could be done next in a time efficient manner, which we will be discussing in the further slides. Coming to what's the problem burden in population and in our country per se, the prevalence in Caucasians is estimated to be 1:10,000 to 1:15,000. However, a study done in India showed prevalence much higher as compared to the general population, that is 1:5,700. But we know that because there is this prevalence is not very accurate because we don't have universal screening program in our country. As we all know that 17-hydroxyprogesterone is recommended as the first year screening using immunoassays, but it is not very accurate when it comes to first 2 days after birth in preterm babies, in patients with sepsis under stress. So genetic screening, however it is more reliable, is not a first tier diagnostic tool in CH and is not recommended by the guidelines also. Coming to our country, CH render genetic diagnosis largely unavailable and unaffordable in India. So from here, Lavanya is going to take over. How we proceeded in this case, she will be explaining in further slides. Over to you, Lavanya.
Good morning, everyone. So let's pause here with our case, get into some interesting facts on the basics of CAH genetics, and then let's come back to our case and see how we really managed her. We know that 21-hydroxylase deficiency is the most common form of CAH, and the gene that codes for this enzyme is CYP21A2, that is located in chromosome 6. Now, this gene is present in close proximity to its pseudogene CYP21A1P. Has anyone come across this term pseudogene? Yes? Okay, so a pseudogene is a non-functional copy of the original gene. Because of some mutation present within the sequence of the pseudogene, it becomes non-functional. It cannot be translated into a protein product. And if you see this entire region in chromosome 6, this is a very complex region where several pseudogenes and functional genes are present in close proximity. So coming back to our gene CYP21A2, each of us usually have one copy of the functional gene and one copy of the pseudogene. But what happens in CAH patients is that because they are very close to each other, during meiotic crossing over, There are high chance of recombination events, and misalignments happening during this process will allow the mutations from pseudogene to be passed on to that of the functional gene. And then you see a disease being manifested in your patient as CAH. And mostly around 90% of the mutations in 21 hydroxylase deficiency are derived from the pseudogene. Coming to the genotype-phenotype correlation in 21 hydroxylase deficiency, we see a direct correlation in around 90% of the cases, and based on the functional activity of the enzymes, the mutations are classified into 4 groups. The null and group A mutations usually result in an enzymatic activity of less than 1%. And if you see the mutations under these categories, they involve mostly small or large deletions and insertions or nonsense mutations. When you have such kind of mutations, what is the expectant result on the protein product? Anyone?
No protein.
Yes. It usually results in a completely non-functional or a near completely non-functional protein. That is why you see a very less enzyme activity retained in this kind of mutations. So usually they produce a truncated or a premature terminated protein product. And what is the phenotype that you can expect in your patients when you have such severe mutations? Exactly. So both this category will involve salt wasting phenotype. And the group B mutations, if you see, they result in 1 to 2% of the enzymatic activity, and group C 20 to 60% of the enzymatic activity. And most of these mutations are actually missense mutation, where one amino acid gets replaced by the other. And based on the differences in the chemical properties of the amino acids being changed, you see the effect on the protein. But however, they are relatively less severe than the truncating mutations. And group B mutations usually result in simple virilizing phenotype, and group C leads to non-classical phenotype. So I'll just repeat the slide again, just a summary. So we have 4 groups of CAH mutations in 21 hydroxylase deficiency. The null and group A mutations, which results in less than 1% of the enzymatic activity, leads to salt wasting phenotype. Group B mutations with 1 to 2% enzymatic activity results in simple virilizing phenotype, and group C with 20 to 60% of the enzymatic activity retained leads to non-classical phenotype. So CAH is an autosomal recessive disorder. So we know that for a recessive disorder, both the alleles have to carry the mutation for the disease to be manifested. And there are different allele segregation patterns in CAH that can be seen. And the most common one here is that when both the partners are carriers, you have a 25% chance of the progeny being at risk of having a classical CAH, and 50% being a chance of being a carrier, and 25% chance of being unaffected. And in autosomal recessive disorders, the allele with the mildest mutation actually dictates the phenotype. So what do I mean by that is, so for a classical CAH to be seen, you expect classical mutations in both the alleles. If a patient has classical mutation on one allele and a non-classical mutation on the other allele, we usually expect only a non-classical phenotype. So this is one common allele segregation pattern. There are also other patterns that has been passed on to you as soft copies in your handouts. You can just refer to that later. So with the high prevalence of CAH in our country and the huge need for genetic testing in CAH, we have established a cost-effective allele-specific PCR-based hotspot mutation screening for 8 pseudogene mutations in CYP21A2 gene. A polymerase chain reaction, or a PCR, is a molecular technique generally used to amplify the target of your interest. And later you need to do some genotyping or sequencing technique to identify the presence or absence of mutation. That's how we generally do. But in allele-specific PCR, it is a slight modification of the conventional PCR, where at the level of PCR itself, you will be able to identify the mutation. You don't have to go for a further downstream technique. So what happens in allele-specific PCR is like, we have 2 PCR reactions, one for the wild-type allele and one for the mutant allele. So when you have amplification only with the wild-type allele, then the patient is homozygous negative. When you have amplification only with the mutant PCR reaction, then you know it is a homozygous positive. When you see amplification in both, yes, in case of recessive disorders, heterozygous carrier. So here the gel image that you see is a representative image of one of the hotspot mutation being screened. So this band at 662 base pair is the allele specific product that has been amplified in the positive control with mutant primers, and you see that there is no amplification in the negative control, whereas the internal control product has been amplified in both positive and negative control, which indicates that the PCR has worked fine. So comparing our samples with positive and negative control, you can see that two samples, sample number 2 and 4, was found to be positive for this hotspot mutation. We have also validated this assay with sequencing methods like the traditional Sanger sequencing and also the advanced NGS method, and we found that this assay was highly specific and sensitive to pick up all the 8 common hotspot mutation, and now it is available on a routine diagnostic practice also. This also went on to be the first report in India to establish a cost-effective allele-specific PCR-based hotspot mutation screening in 21-hydroxylase deficiency. So I hope we got a glimpse of the basics of 21-hydroxylase deficiency genetics. Now let's come back to our proband. Just to recall, she was a classical salt-wasting CAH subject with her 6th week of pregnancy. So what can be done in a time-efficient manner? So now that we have established the genetic testing, we went on to screen the proband for the hotspot mutation, and she was found to be positive for this I172N mutation, again validated with Sanger sequencing. So this mutation is a missense mutation falling in group B of CAH mutations. If you remember, I have told that group B mutations usually result in simple virilizing phenotype. But this patient presented with salt wasting phenotype. So can you think of a reason why such heterogeneity was seen? Okay, so let's go back to this slide. So if you see, the group B mutation have 1 to 2% of the enzyme activity retained. And if you see salt wasting mutations, the enzyme activity is less than 1%. And our mutation that was identified in the proband falls here, I172N. So if you see the difference in the enzymatic activity, it's a very narrow difference, less than 1 to 2%. So this is because of this you see such heterogeneity which usually exists in this mutation in CAH patients, and I172N has been reported to be associated with 25% of salt wasting cases in CAH. So what can be done next? Now the genetic cause in the proband has been identified. So what do you think we can do next? So we have the genetic assay in our hand now. So we went on to screen the partner also. The partner was now available for genetic testing, and the partner was also identified to be a carrier of classical CAH mutation. Now the proband is homozygous positive and her partner is heterozygous carrier for classical mutation. So, looking at these different pedigree charts, which among these do you think will best suit the family that we are discussing about? Yes, exactly. So here we have the mother who is a homozygous classical CAH mutation positive and the father who is a heterozygous classical carrier. So the progeny is at a risk of having CAH at 50%. So that is our main concern. So in such scenarios, we usually start dexamethasone to prevent androgenization in the fetus if the fetus is a female. So what do you think can be done before, or like started with dexamethasone, but what are the other alternatives that can be done here in view of genetic testing? Yes, that is one option. But what we did here was we did the prenatal diagnosis with chorionic villi sampling. So with karyotyping, the subject was found to be a female, so that even increases the risk of the fetus having a classical CAH. However, with genotyping, this fetus was found only to be a carrier for I172N mutation. The other allele was completely normal. Now we know that the genotype of the fetus is only a heterozygous carrier. So do you think we should continue dexamethasone? Yes, it is not required. So we actually shifted the mother to hydrocortisone, stopped dexamethasone, and her pregnancy was monitored as usual. And we also followed up the baby with newborn screening, and we genotyped the baby with a newborn screening sample. The carrier status was again confirmed, and the baby is doing fine now. So this is one classical example indicating the need for genetic testing in CAH. First of all, we identified the genetic cause in the proband. Then we offered carrier testing and identified the carrier status of the father. And we also could do a prenatal diagnosis for the fetus, which had a direct intervention in the therapeutic management. So that is to do with our first case. So any questions?
Ma'am, at what age you did gestation which you did chorion from the sample?
We did it at 12th week of gestation.
Good morning, everyone. Second case is a 22-year-old female who presented to adult endocrine OPD with complaints of cyclical menorrhagia since menarche. She attained menarche at 12 years of age. She had regular hematuria during the time of periods. That's what her major concern was. So coming to her antenatal history and birth history, she is a second born of a non-consanguineous marriage. There was no significant maternal history of any drug intake during pregnancy. She was born through a normal vaginal delivery and had normal birth weight. However, noted to have ambiguous genitalia at birth. She did not have any history of salt wasting crisis. She had no hypertension. There was history of short stature noted since childhood. There was no significant family history. She was started on hydrocortisone at 3 months of age. She was compliant with medication, did not have any hospitalization in the childhood. At 9 years, she presented to us, and during that time, she underwent a feminizing genitoplasty with reduction clitoroplasty, and she was on hydrocortisone at presentation. Coming to her examination, she had short stature compared to her parents. Her vitals were stable. She had features of virilization with an FG score of 16. However, there was no hyperpigmentation. Her tannus breast was 5 and pubic hair was stage 4. This is her genital examination, was showed a reduced clitoris with dimension of 100 clitoral index of 100 millimeter square. Her anogenital ratio was 0.6. She had a single opening in a small vestibule. The differentiation between urethral opening and vaginal opening was not distinct. Coming to her investigation at presentation, her 17-hydroxyprogesterone at initial presentation was more than 20. Her DHEAs were in the normal limits. She had low cortisol and elevated ACTH levels. She had reduced plasma renin activity. Her karyotyping was done outside, which showed a 46XS genotype, and her electrolytes at presentation was normal. So any thoughts on etiology of cyclical menorrhagia in this patient in the background of CAH?
Urogenital sinus is not there.
This is what we also look for, this is the MRI of the pelvis. This is the bladder, and this is the urogenital tract, and this image is showing a persistent urogenital sinus. The coronal section also showing the same. This is the anterior part is the bladder, and the urethra, and posterior is the vagina, and the common persistent urogenital sinus. So this is an 18-year-old girl who was diagnosed with congenital adrenal hyperplasia at 3 months of gestational age. When she presented with ambiguous genitalia, she did not have any salt wasting crisis. She was normotensive, and she was on hydrocortisone. What could be the differentials? So this is the symbol virilizing CAH, and the second we also thought about a non-classical CAH with 11 beta hydroxylase deficiency. The classic form present with hypertension, but non-classic they can present like with ambiguous genitalia also. So we went on with the genetic analysis. The genetic part Lavanya will cover.
So coming to the results of genetic investigations in this patient. So we went on to do a hotspot mutation screening with allele-specific PCR that turned out to be negative, and long-range PCR-based analysis for large rearrangements were also negative. So what we did next was utilized MLPA, or multiplex ligation dependent probe amplification, It is a relative molecular technique to identify copy number variations, usually to detect large deletions and insertions in a gene. That was also found to be negative. So what do you think we can do next?
Look for other gene mutations.
Yes, possibly what genes? She presented the differential. Yes. So we went on to do an NGS based screening for 5 genes in CAH. That also turned out to be negative, and this panel again included 11 beta hydroxylase deficiency. But in view of strong clinical presentation, further investigations under process in this subject are to look for small deletions and insertions at the level of exons using some PCR based assays. If that also turns out to be negative, then we will go about doing a clinical exome or whole exome sequencing to look for other genes related to CAH to know what is the genetic cause in this proband. Because the 21 hydroxylase gene CYP21A2 is complicated with the presence of pseudogene CYP21A1P, it is very difficult to get primers within the gene sequence because it has high homology with the pseudogene sequence, around 98%. So it is highly difficult to get primers within this gene. So what we usually do is like have a forward primer just before the promoter region of the functional gene CYP21A2, and we have the reverse primer somewhere in the neighboring gene TNXP for the functional gene. That will make it specific, and you will be able to amplify the functional gene without any contamination of the pseudogene. And the length of the PCR product that we get here is around 6000 base pair. So anything above 3000 base pair, we usually call it as a long range PCR, because usually the conventional PCRs that we do are of shorter size. So here we do long range PCRs to amplify the functional gene separately to identify mutations in functional gene. We also amplify the pseudogene separately because performing few restriction digestion techniques in these two genes will let us know if there are large rearrangements between these two genes. So with our experience, we have actually developed a pipeline for CAH genetic testing in our lab. So when you suspect a subject for 21 hydroxylase deficiency, we extract the DNA and then we do the long range PCR and restriction digestion for both the functional and the pseudogene. That will help you identify if there are large rearrangements between these two genes, and the results will be validated with MLPA, and we go about doing a phenotype-genotype correlation. When large deletions and rearrangements are ruled out, we do this allele-specific PCR-based testing to identify 8 common pseudogene-derived mutations. The positive ones are being validated with Sanger sequencing, and family screening is also performed for the available family members. If this allele-specific PCR mutations turns out to be negative, then we go for NGS screening. Or if you suspect other forms of CAH in your patient, then we will directly go for this NGS-based testing for 5 genes. Now we have added 2 more genes and we are further working on to add other genes also. So here we do a target enrichment for the 5 genes, and sequencing is performed on ion torrent PGM. So we will be explaining these techniques in little more detail when you actually visit our lab, and the ones that are positive with NGS are again validated with Sanger sequencing. So this is how we do genetic testing in our lab for CAH. If that also turns out to be negative, then we can think of going about a clinical exome or whole exome sequencing.
So based on our results, we actually found that the allele-specific PCR could provide a confirmed diagnosis for a significant proportion of patients with CAH. The positivity yield was 88.7% in 72 subjects in our cohort. And this tool was so promising to be used as a first-tier diagnostic tool in genetic screening for 21 hydroxylase deficiency. However, the NGS strategy was beneficial for those with hotspot mutation negative and also with other forms of CAH. We also found that NGS analysis in 21 hydroxylase deficiency is highly complex because you have a pseudogene. We need to really go about looking for ways how you can align these reads only to the functional gene and not to the pseudogene. So in case of rearrangements, it's really challenging. But when you rule out the rearrangements and you find them to be negative for hotspot mutation, then it is highly beneficial to pick up the other non-pseudogene derived mutations. And we have identified such mutations in our cohort also. And together with this comprehensive strategy of using long-range PCRs, then allele-specific PCR and then NGS, has increased the diagnostic yield to 97.2% in our cohort. So that is to do with our second case also.
Good morning, everyone. The second session is on the genetics of insulin resistance. So coming straight to our first case, we are presenting a 19-year-old gentleman who was referred to us for the management of diabetes at the age of 17 years. He was diagnosed to have diabetes at the age of 17 years while he was hospitalized for fever. The initial blood glucose was more than 500 milligram per deciliter. There was no history suggesting any diabetic ketoacidosis, steatorrhea or abdominal pain. He was on premix insulin since diagnosis and the total insulin requirement was more than 100 units per day with suboptimal glycemic control. And in 2018, he was diagnosed with chronic liver disease and while he had an episode of swelling of feet, abdomen and breathlessness. And he underwent esophageal variceal ligation for varices. His antenatal birth and developmental history were uneventful and he had above average scholastic performance. He was born to a third-degree consanguineous marriage and had an elder sibling who died at the age of 5 years due to jaundice. The etiology workup is not available. On examination, the BMI was 15.1 kg per meter square with grade 4 acanthosis in the neck, around the eyes and axillae. There was a muscular appearance with loss of buccal pad of fat, generalized decreased subcutaneous fat all over the body. Phlebomegaly was also present. There was umbilical hernia and abdominal examination showed hepatosplenomegaly with evidence of fluid inside the abdomen as shifting dullness. The Tanner stage was P3. The investigations showed bicytopenia due to chronic liver disease and required 3 units of blood transfusions. The triglycerides were 180 mg per deciliter but was on treatment from outside. The C-peptide levels stimulated was 9.87 nanogram per ml. The workup for chronic liver disease, including the autoimmune workup, was negative. Coming to the body composition, the mean total fat percentage for a male at 20 years with a BMI of more than 21 kg per meter square is 28.3. However, in our subject, the total fat percent was only 16.1, which lies between the 15th and the 10th centile, which is appropriate for the age and the sex. We can see in the body composition there is a generalized loss of subcutaneous fat in this case. So what do you think the diagnosis could be in this case? And so we went ahead with the genetic analysis. The genetic analysis revealed a novel deletion in the exon 4 of BSCL2 gene, which caused a frameshift mutation followed by the premature termination at codon 211. And ACMG had classified it as a likely pathogenic lesion. So these are the genes analyzed in our molecular lab as a part of the insulin resistance panel, which are laminin A, AGPAT2, BSCL2, PPAR gamma, insulin receptor gene, and zinc metallopeptidase gene. Coming to the second case of the day. So this is a 16-year-old girl who was diagnosed with diabetes mellitus while she was evaluated for osmotic symptoms. The initial blood glucose in this condition was also more than 500 mg per deciliter and there was associated hypertriglyceridemia. There was no history suggesting any diabetic ketoacidosis, abdominal pain or steatorrhea, and the patient was on insulin since diagnosis with suboptimal control. There was also associated oligomenorrhea since menarche. She presented to us for further management at the age of 23. In the family history, we can see that there is a strong history in the maternal side. Her mother, maternal uncle and maternal grandfather had a round face. Distinct round faces were there and they all were affected with diabetes mellitus around the age of 30 years. Her younger sister also had a similar round face and subsequently in her life she also developed diabetes mellitus while she was around 16 years of age. On clinical examination, the proband had a height of 158 centimeters with a BMI of 17.6 kg per meter square. There was grade 2 acanthosis and round Cushingoid features without any plethora or other discriminatory features. There was prominent muscular contours and phlebomegaly. The FG score was 11 by 36. And the mother also had a Cushingoid appearance without any plethora, phlebomegaly and muscular habitus were present. So this is a picture of the mother as well as the proband. We can appreciate the distinct round face on them and also muscular appearance with phlebomegaly. both in the upper limbs and the lower limbs. Investigation showed that the triglycerides were 228. However, she was on treatment already from outside, and the stimulated C-peptide levels were 3.1 nanogram per deciliter. Here in the body composition, the mean total fat percent for a female at 20 years of age is 32.5. However, in our case, this lady is having a fat percent of 22.3 at the 5th centile, which is grossly reduced. And we can also see a distinct redistribution of fat around the neck and also on the face. So we went ahead with the genetic analysis. Next generation sequence revealed that the proband and the mother were positive for the reported heterozygous hotspot missense mutation in the laminin gene, and it was later confirmed by Sanger sequencing.
Thank you, Dr. Ann, for the description of cases. So now we'll be seeing a brief review on how to approach a case of lipodystrophy and a little bit on genetics of lipodystrophy. So as we all know, lipodystrophy is characterized by either partial or complete loss of fat. And looking at the picture, we know that in the formation of a mature adipocyte, there are various genes being involved in the differentiation of an adipocyte. And genetic mutation in any of this, a mutation in any of this gene could result in lipodystrophy or lipodystrophy-like syndromes. So I'll ask you a question. We keep on saying that there is loss of adipose tissue. So why there in lipodystrophy is, what is the reason for metabolic complications in lipodystrophy, which is basically because of fat? We say on the one hand that there is loss of adipose tissue, and why there is metabolic complications?
Adipokines are not secreted, which
Yeah, that's the reason. The good adipokines like leptin is reduced. And we should understand that there are two types of adipose tissue in the body. The one is white adipose tissue, which is the predominant one, constituting about 99%. And this white adipose tissue is actually the main storehouse of energy. The fat is stored in the white adipose tissue as neutral lipids. So when there is loss of this white adipose tissue from the areas in which it should be actually present, what happens is this fat start getting deposited in non-adipocyte areas. For example, in the liver, in the muscles, in the pancreas, which will lead to insulin resistance, and that is post-receptor insulin resistance and cardiometabolic complications. So as we approach any case of any disease for that matter, it should be first a proper clinical history examination, and then relevant investigations, evaluation for complications, and then treatment. So now I would like you people to answer. Like I'm sure that every registrar here at one point in time during your clinical evaluation would thought lipodystrophy as a differential diagnosis in any patient. So what are those factors which make you think or make you suspect lipodystrophy in any patient? You can take clinical clues from the cases presented as well.
Normal
fat
BMI,
redistribution.
severe acanthosis.
Yeah, fat redistribution, signs of insulin resistance, like very severe signs like grade 4 acanthosis. Okay.
Insulin required, if they are on insulin, the requirement more than 200 units per day.
Yeah, more than, yeah, they tell either 200 units per day or more than 2 units per kg per day. Yeah, features of metabolic syndrome. I think that sums up most of the things. So the first, these are two of our patients with complete generalized lipodystrophy. We can notice that they both presented with early onset generalized loss of body fat and with, of course, with diabetes mellitus. So we can also notice that they had a prominent muscular appearance, and on close examination both of them had prominent veins, that is plebomegaly. And typically patients with generalized lipodystrophy, they have acromegaloid facies. That is very important. Well, going through the cases, I just found that at least in 2 patients, acromegaly was considered as a diagnosis in the first visit, and IGF-1 levels and growth hormone suppression test was in fact done to rule out acromegaly. So that is also an important clinical clue which you have to keep in mind. As said, like in partial lipodystrophy, they can have a redistribution of fat resulting in Cushingoid appearance, and they can have signs of insulin resistance. And as rightly said, they can
present with features of metabolic syndrome like fatty liver, hypertriglyceridemia, and polycystic ovarian morphology. However, in a metabolic syndrome, we expect the patient to be morbidly obese or generalized obesity. So, when we find that there is a difference in the distribution of fat, we should keep lipodystrophy as a differential diagnosis. So, can someone tell me what is the importance of family history in lipodystrophy?
Many of them are autosomal recessive.
It is recessive.
So, predominantly the generalized ones are autosomal recessive and the partial ones are autosomal dominant. So, what is the importance of family history in case of an autosomal recessive disorder? Yeah, history of consanguinity. So, what is the implication? So, why is genetic screening important in an autosomal recessive disorder?
Prenatal diagnosis and counseling.
Yeah, it's to identify the carriers basically, so that you prevent the disease being transmitted in the future generations. So, what is the importance of family history in autosomal dominant condition in partial lipodystrophy?
Early treatment.
What will you find in the pedigree? You saw in the second patient, you looked at the pedigree, there was a beautifully drawn pedigree. What was noted in the pedigree? There were multiple family members affected in the pedigree. So there will be multiple family members affected. And what is the importance of genetic testing in an autosomal dominant disorder? Yeah, if as Dr. Ann rightly pointed out that the younger sister at diagnosis didn't have diabetes. In fact, based on the phenotype, we did the genetics after the elder sister was diagnosed, and she also turned out to be positive for the mutation. So, identification of a genetic disorder in them will help us to anticipate the future complications and an early screening. So, the next we will look at the distribution of fat to look at whether it is a generalized type which results in complete loss of fat or a partial type whether there is a redistribution of fat. Now coming to the types of congenital generalized lipodystrophy, this is commonly known as Berardinelli-Seep syndrome. And what are the mutations known? Already you said two mutations, that is AGPAD2 and BACL2, which are responsible for type 1 and type 2 respectively. There are two other genes related to that. Yeah, caveolin is type 3 and PTRF, which is the type 4. So the relatively common ones are AGPAD2 and BACL2. So all books mention that the difference in when they mention that there is preservation of mechanical fat. Mechanical fat they mean the fat which is present in the palms and the soles in an AGPAD2 mutation, and BSL2 is associated with loss of mechanical fat as well as it is associated with severe metabolic complications than when compared to AGPAD2. So, can someone tell me what are the genes implicated in familial partial lipodystrophy? Laminin, PPR gamma. There are multiple genes being implicated. There are the list is long, more than 10 actually. I have just put up 5 genes here. The type 1 variety is commonly known as Cobberling type, in which there is loss of fat from the limbs and deposition in the trunk and in the upper part of the body, that is in the neck and the face. It is typical like a Cushingoid feature actually. So, like a Cushing's patient. However, the gene implicated with this is not yet identified, the loci is not yet identified, unknown, and it is said that it has a polygenic inheritance probably. The type 2 and 3 are the common ones. The type 2 is known as Dunnigan type, which is because of laminin A mutation, and the type 3 is because of PPR gamma mutation. A difference in the clinical phenotype of these two I will be coming shortly. So, just a brief word on acquired lipodystrophy. The acquired generalized form is known as Lawrence syndrome, named after the scientist who described it. So, this has a female preponderance. In general, the congenital forms, the gender distribution is equal. Male is to female ratio is 1:1. However, in both the acquired varieties, there is a female preponderance because it's associated with autoimmune process. So the acquired partial type, the most common one is associated with HIV infection. However, there are other forms like very rarely it can occur following bone marrow transplant, and it can occur following viral infections, which is being first described by Baraker and Simon. So now coming to in nutshell, how do we approach a case of lipodystrophy? So when a patient presents with generalized or partial loss of adipose tissue, what is the first thing we will do? Before jumping into, we know that lipodystrophy is a very rare disorder, relatively rare. It's a rare disorder actually, for that matter. So before jumping into a diagnosis of lipodystrophy, so there are certain things which we should rule out. So you imagine typically a patient presenting like this with generalized loss of body fat. So the patient, what the patient perceives is maybe the patient has lost weight or something. So what are the things which you will rule out in such cases? Important diagnosis to be ruled out. Acromegaly is one thing, yeah, based on that acromegaloid appearance. Any cause of severe weight loss. So you would have come across patients with pancreatic diabetes who look severely emaciated if they have exocrine insufficiency associated with this, and even patients with diabetes who are not on regular treatment, who have uncontrolled hyperglycemia for a prolonged period can have severe weight loss, and other disorders like anorexia nervosa. And yet another group of disorders which needs to be kept in mind is insulin resistance syndromes, that is leprochonism and Rapson-Mendenhall syndrome. Leprochonism, though, has a very limited lifespan, doesn't come into the differentials as well at all. But Rapson-Mendenhall syndrome, yes, but it has typical dysmorphic features based on which it can be ruled out. So next point is we look at the extent of fat loss, whether it is generalized or partial. In case of a generalized, this is all what we discussed already. There will be early loss of fat and there is a history of consanguinity. It's more towards a congenital etiology. If it's a little late onset of fat loss and associated autoimmune etiology, female preponderance, it's more towards an upward etiology. So partial lipodystrophy, where in a partial familial one, multiple family members can be affected, and in the upward form, again, it can be related to autoimmune disorders. So this is already, Dr. Anne has described that there are 6 genes which are done as a part of insulin resistance panel in our lab. And when I went through our cases, like over a period of 10 years, there were 27 patients in whom we thought that based on the clinical features, we thought that they had insulin resistance, some forms of insulin resistance syndrome, and they were screened using this 6 gene panel. And among them, 6 turned out to be positive, 3 had generalized lipodystrophy, and 3 had partial lipodystrophy. So these are the 3 patients who had generalized lipodystrophy. So the clinical features in all of them remain the same. But I would like you to concentrate on this, that in contrary to what is thought, that the first thing when we think of lipodystrophy, insulin resistance come to our mind is that they require very high insulin doses. Despite that, they will have a suboptimal control. Even a patient with congenital generalized lipodystrophy was managed with metformin and pioglitazone alone with a good glycemic control. Her HbA1c was 7% in 2 consecutive visits. And we had 3 more cases of partial lipodystrophy. These 3 cases belong to the same family, the family which we presented, a mother and the 2 daughters. And there were 3 cases. Other than this, there were 2 more cases. 2 were positive for laminin A and 1 was positive for PPR gamma. And among the 5 cases of partial lipodystrophy, 3 were able to be managed with insulin sensitizers alone. And even the C-peptide, we expect that the C-peptide levels will be very high in case of a lipodystrophy. So we saw that in the second case we presented, the stimulated C-peptide was only 3.1, which is not very high. So it's not like just based on one factor that we should make a diagnosis, that we should not expect that all the factors should be fulfilled for making the diagnosis. It all depends upon the clinical presentation, the examination, the clinical findings and everything, and as well as we can confirm it using the biochemical test.
There are practical issues in doing your C-peptides. You say stop insulin, but then when you stop insulin, the sugars might shoot up quite high, and they may not be controlled before they come in. So there may be an element of glucotoxicity which has contributed towards the C-peptide secretion being low. Or the lipodystrophy might have been present for a long time with long-standing diabetes, and the beta cell function might be declined. So we don't get perfect pretty pictures when we start looking for these patients.
So another interesting thing which we noted in our patient as well as has been described in literature. So if we have a patient of partial lipodystrophy, and before getting on into the genetics, whether any clinical clues like distribution of fat or the body composition data, can it give a clue whether it is PPR gamma or laminin A mutation? So as we know, the typical clinical picture which is described is loss of fat from the abdomen and the limbs and the deposition in the head and the neck region, leading to the Cushingoid appearance, which is very classic for laminin A. So this is the body composition of our patient with a laminin A mutation. So we can notice that there is loss of fat from the limbs and there is trunk and there is deposition of fat in the head and neck region. And also when we look at the hypertrophy, that is which we typically describe as pseudo hypertrophy in lipodystrophy, this is more pronounced. The pseudo hypertrophy is more pronounced in a laminin A mutation. On the contrary, in a patient with PPR gamma mutation, this is as well as this is a body composition of our own patient. So we can notice that there is loss of fat from the limbs and from the trunk. However, there is no increased deposition in the neck and in the head. And also the pseudo hypertrophy of the muscle is not well pronounced in the PPR gamma. So even before going into the genetic diagnosis, maybe we can have a clue from the clinical picture as well as from the body composition what type of partial lipodystrophy that it could be. So now coming to the complications of lipodystrophy, this I think everyone is familiar with. What are the various metabolic complications associated with it? So it's a very common thing: diabetes, hypertriglyceridemia, polycystic ovarian syndrome, and fatty liver. So and also it's known that due to various comorbidities, these people are prone for early mortality. The morbidity is very high in them. So the treatment of lipodystrophy, the only FDA approved drug as of now is metreleptin for children more than 2 years, those with congenital generalized lipodystrophy. In few countries like Japan and European countries, it's also approved for partial lipodystrophy when the other agents are not adequate to control the metabolic complications. And in addition, we can use insulin sensitizers like metformin and pioglitazone, and insulin can be used for glycemic control. And other management of comorbidities are same as for other cases of diabetes. Thank you.
Thank you, Ramya. I'd also like to highlight the fact that partial lipodystrophy could present with something other than diabetes. For example, the hypertriglyceridemia may be a dominant factor, and diabetes may or may not even be there in the initial case. Fatty liver may be a dominant feature. So if you do an ultrasound abdomen for a young diabetic patient who is lean and you get a fatty liver, grade 2 and above, this is not going to be type 1. It is not going to be FC, hypercalcic pancreatic diabetes. There's something else that you're doing. Thank you so much. I'd like to introduce Professor, put a mental block. Sophy, whom I've known for the last 20 years, and who's a professor in pediatric endocrinology. She'll be talking to us about congenital hyperinsulinism.
Thank you, sir. Thank you for this opportunity. So, good morning. Pre-T session, pre-lab session, so we'll make it fast. We'll make it interactive as well. So, in this talk on overview of congenital hyperinsulinism, what my objectives are for you to understand how we diagnose it, what are the types, what are the genetic aspects that we need to be aware of, and a basic approach to treatment, and some time for you to ask questions as well. So we'll look through these aspects through the story of two cases. The first is a newborn who came to us at 15 hours of age being referred for hypoglycemia. He was born as a second child to consanguineous parents. The mother was unbooked. She had gone to a local hospital and underwent cesarean section as the baby was large at term, and baby was born with a birth weight of 4.55 kg. So it was a large baby who had cried at birth and did not have any immediate neonatal concerns till about 2 hours of age, when he was noted to be lethargic. And at 12 hours at the local hospital, the doctor had done a GRBS and picked up a value of 40. He had started an umbilical venous line with dextrose infusion, given 1 dose of antibiotic, 1 dose of hydrocortisone, and promptly refer the patient to our care. This baby presented symptomatic with jitteriness and GRBS value of 38 on a GIR of 7.6 milligram per kg per minute. So what are your thoughts? Does this baby have significant hypoglycemia? Would you be worried about? And what's your thought on LGA, the baby having a weight of 4.55 kg? Yeah, it could have been very well a baby born to a mother with diabetes, because we don't know that the mother was not tested. She was an unbooked mother at that center. So that detail is an important piece of information that we need to gather. So, what is the cutoff for us to say this is hypoglycemia? And so the thing is, we become very preoccupied with cutoffs, don't we? So what we need to know is that the GRBS value in a neonate is very much dependent on, are they term, are they preterm, are they small, what is their birth weight, and also where they are in their life, how many hours was that value picked up after they were born. This is because physiologically, in utero, the fetus gets a continuous supply of glucose from the mother through the placenta. But what happens after the baby is born? Umbilical cord is cut, the babies become an independent unit now, and then what happens to the glucose values? There is a physiological nadir. So, about 1 to 2 hours after birth, it can go down up to 25. That's physiological. And then what kicks in? Baby's own glycogen stores need to be utilized. Baby needs to activate its gluconeogenetic enzymes, and baby starts feeding on mother's milk and needs to learn to utilize fat also now as a source of fuel. So this whole process leads in a physiologically wide range of GRBS values in the first few hours of birth, which can go on up to first 72 hours, ranging from 25 to 112. After that, the range sort of narrows down like an adult almost. So the Pediatric Society guidelines actually teach us that you need to be aware of an operational threshold for hypoglycemia. Rather than thinking of it as, yes, this is the cutoff diagnosis for hypoglycemia, we need to think at what level should I act. Okay, so what the guideline says, within 48 hours of age, take a plasma value of less than 50 to initiate treatment. At more than 48 hours, take a plasma value of less than 60 to initiate any treatment. And symptomatic child, less than 40, initiate treatment. So easy numbers to remember, 40, 50, 60. But what are the causes? Like someone pointed out, this child could very well have been a transient hyperinsulinism. So transient hyperinsulinism occurs not only in infant of diabetic mother, can also happen to a newborn who's born with perinatal stress, some asphyxia, some RH isoimmunization. All of these things can cause transient hyperinsulinism. When it becomes persistent is when you think of, can this be congenital hyperinsulinism? It can also occur hypoglycemia because of baby being born small, because baby has sepsis, increasing the utilization of glucose, or in the cases of certain endocrinopathies like multiple pituitary hormone deficiency, adrenal insufficiency, inborn errors of metabolism, can also happen in newborn who are polycythemic. So, a good detailed history is of utmost importance in this newborn who's come with symptomatic significant hypoglycemia at 15 hours of age. So, what happened to our baby? So, we gave dextrose bolus, started the child on higher percentage of dextrose. Baby was on 13.4 of GIR after coming to us, and we did collect critical samples. So, that is an important thing to do, to be able to collect paired samples of plasma glucose with concomitant insulin. Typically, we also collect cortisol and growth hormone levels. Important thing to remember is that in the neonatal period, there is a blunting of the cortisol and growth hormone response. So, you may use these values to screen, but you don't use these values to diagnose and treat the child as cortisol deficient. Especially when they've received one dose of hydrocort, and if you've collected the cortisol immediately after that, there could be a blunting of the cortisol response. So one needs to be aware of that. So now you have the values in front of you, two values of 14 with concomitant 40.8 of insulin, 37 with concomitant 9.5. What do you think? Does this baby have hyperinsulinism? Likely. So we suspect based on our GIR requirement. If there is a persistent need for a newborn to get more than 10 milligram per kg per minute of glucose delivery, that is when you suspect this is hyperinsulinism. And for us to diagnose, we need to get a paired value of any detectable insulin level with the plasma glucose of less than 54. So normally insulin should shut down during hypoglycemia. So even any detectable insulin level is good enough for us to diagnose CHI. And important to remember that 2 or 3 paired samples of this diagnostic values have to be obtained for us to be sure it is not just a simple transient hyperinsulinism, but actually a genetic or a syndromic congenital hyperinsulinism. There is an easy way of calculating GIR, as I've highlighted there on the box. So I think you need to be aware of that, so that when you go to see a baby or a referral, you can easily calculate the GIR based on ml per kg per day of fluid, percentage dextrose that the baby is on. So what do we do with this baby in our hands now? 15-hour-old, symptomatic, day 2 having recurrent hypoglycemia. So we had just got 1 critical values of bloods on day 2. We also thought child was symptomatic with significant jitteriness. So actually we went on to do a partial exchange transfusion because baby was polycythemic, and that itself can be one of the reasons for hypoglycemia. However, this baby continued to have hypoglycemia even after that. So we had initiated glucagon infusion. What is the worry with prolonged duration of glucagon infusion? Rebound hypoglycemia. So we got, by now we were more or less confident that this baby has congenital hyperinsulinism, and so we initiated the baby on diazoxide. Normally, how much do you give diazoxide? Do you know? Yeah, you start off with 5 mg per kg per day, can go up to 20 mg per kg per day. And how does diazoxide act? Keeps the potassium channel open, and then thus cuts down the insulin production. So insulin release. So this baby was started on diazoxide and went on to have a complicated neonatal course because of hospital acquired sepsis. And finally, by day 32 on full feeds, having been completely treated for sepsis at a dose of 15 milligram per kg per day, with ensuring 2 to 3 hour euglycemia, 2 to 3 hour of fasting euglycemia, we could discharge the newborn. So this baby has diazoxide responsive hyperinsulinism. Typically, when we think of how do we approach treatment, we need to first establish this. Is the baby diazoxide responsive, or is the patient diazoxide unresponsive? At this point, knowing that it is diazoxide responsive, do we need to do anything else, or are we happy to send them home and have regular follow-ups? Do you want to know why the baby has hyperinsulinism? Why is it diazoxide responsive? It is important to know. Probably, yeah, genotyping, somebody said that. Much more important in an unresponsive form, but still in diazoxide responsive form, because quite a few could be autosomal dominant, autosomal recessive. There is a chance of recurrence in the next baby. What is the prognosis in this baby? Certain forms might even need treatment for hyperammonemia. So we definitely need to know what is causing this responsive form. And why is it important to pick this up early and treat aggressively? Why is it so important to go up on the GIR? And all that is because we want to prevent the permanent brain injury that 1 in 4 or 1 in 2 of the children that you're treating could develop. So that high is the risk of permanent brain damage. Typically, it can affect the occipital area with gliosis, which can result in cortical visual insufficiency. So imagine having a newborn you've treated, done well, and at follow-up you realize child is not focusing on the mother's face, and you actually figure out that child has cortical venous insufficiency. So it's a wasted effort then. Whatever we have done, we have not managed them appropriately. So that is why picking up suspecting hyperinsulinism and diagnosing, treating, ensuring euglycemia is of utmost importance. So this just summarizes the steps that we go through. You manage the hypoglycemia, collect critical samples, initiate diazoxide, look for responsiveness, and then move on to why do we have this. So move on to genetic testing and, if necessary, a DOTA TET scan. So while we are looking at what causes, let's just quickly go through what happens in the beta cell. So glucose enters the cell through the GLUT2 facilitative transporter mechanism, comes inside, gets phosphorylated by the glucokinase enzyme, and glucose 6-phosphate then undergoes glycolysis through Krebs cycle. There is an ATP production. When there is an increased ATP-ADP ratio, that makes the potassium channel to close. That causes calcium to enter through these L-type calcium channels, and that causes release of insulin. So a stimulus coupled response is what we see in glucose insulin homeostasis within the beta cell. So genes which code, when we think of CHI, we think of genes which affect the channels, such as the potassium channel, the calcium channel. And then we also think of the genes which affect the enzymes involved, such as the GLUD1, where you can have hyperinsulinism with hyperammonemia, and the glucokinase enzyme. And finally, you also need to think of the transcription factors. Histologically, when you think, you need to be aware that there are three types: a diffuse type, where there are multiple pockets of acinar cell involvement producing more insulin. Then there is a focal type, where there is a 2 to 10 millimeter focus of 2 to 4. This is also the diffuse, actually. This is, yeah. So a 2 to 10 millimeter focus of increased production of insulin, along with destruction of the architecture of the cell. And then there is an atypical type, where there is a bigger focus. So it's a focal multiple areas, but each area is more than 10 millimeter with preserved acinar architecture, and that is referred to as an atypical type. And we can differentiate that by doing a nuclear scan. We can also do it histologically on post-pancreatectomy patients. So we went on and did a genetics for this baby, and that showed a positive mutation in the glucokinase gene. So an activating heterozygous mutation is what is associated with CHI. Where are inactivating mutations of the GCK gene seen? MODY and neonatal. If it's homozygous, it will be neonatal diabetes. If it is heterozygous, you will see that in MODY. So this child had a heterozygous. It's an autosomal dominant condition, and an activating mutation causes hyperinsulinism. We also figured out that child had a focal uptake in the uncinate process of the pancreas. With time, the baby actually outgrows the diazoxide dose. When we give more than 7 mg per kg per day of diazoxide, we worry about fluid retention. So we start them prophylactically on hydrochlorothiazide as well. And at nearly 5 years of age, this child is doing well with normal growth, normal development, no seizures, no vision problems, maintaining euglycemia on dose that the child has grown into, and currently on only 5 mg per kg per day of diazoxide. So glucokinase gene, like we went through in that earlier picture, it almost sort of tags your glucose entry to the insulin release. So if this enzyme is mutated, then insulin can get released at a lower threshold of glucose, and that is what happens in GCK CHI, and it's supposed to occur at a variable severity. So you could have severe neonatal hyperinsulinism forms. Activating heterozygous mutations can also present in later childhood and even in adulthood with insulinoma-like picture. So that's also been described. But the best thing is majority will be diazoxide responsive, because your potassium channels are intact, and so majority are diazoxide responsive. Very few case reports of unresponsive forms have also been described. So important to get genetics done to know the future for this child and to prognosticate and explain to the family. Here we do have a comprehensive NGS-based screening panel for hyperinsulinemic hypoglycemia established under Dr. Nihal's guidance by Dr. Aaron and team. So we are very privileged. When we see a child, we just need to send a 2 ml EDTA in-house, whether they can pay or they cannot pay. We are very fortunate that we can get our results very fast thanks to our lab team, and they do screen for, they do look for 10 genes as part of this panel earlier. And does Dr. Aaron want to?
So we're going to look at this workflow when we visit the labs, but we have established a 10 gene panel already, and we have got an ICMR funded project now, current project, where we are able to actually expand the panel up to 30 plus genes, and what we are looking at is how we can have the results quickly. I mean, the fastest turnaround time, because many times when Dr. Sophy sees this patient, the most important thing is when we will get the result. Yeah? So we are hoping that we should be able to have a test where we can release the report in less than 48 or 72 hours max. So we are now working on that assay, and we've got some excellent data just yesterday. So we have an assay established for an extended panel, and we have a 10-gene panel, and we'll share the details when we visit the lab. Yeah, it's very important. And this TCK heterozygous mutation is a reported mutation already in CHI. And also, it's a heterozygous, so there is you should also rule out that it is not inherited from parents. And if you imagine if you have identified a heterozygous variant, and then you do a family screening and it is inherited from the father who's normal, then you know that this is not the mutation. So it's a de novo mutation. We need to see that both the parents are negative. So all that workup is what makes, at the end you'll be able to kind of release a report. So this is not just finding a mutation. Sometimes probably you have to extend and screen the parents, and then only you'll be able to interpret the results. So these details we'll learn a little more when we visit the lab.
So let's move on to the second case. So this baby was born to a mother who had rather had a tough obstetric period. She had had 3 abortions and she had only 1 living child. And she was again consanguineously married. And she had delivered her second living baby now at term with 4.32 kg weight. So again, large baby. So typically the mean weight in a hyperinsulinism baby is supposed to be above 3.7. The minute they cross 4, you are sort of, thinking, can this be hyperinsulinism? And this baby had a low value of 24 noted at 2 hours of age. And by the time we saw the baby in few hours after life, the baby was requiring a GIR of 21 milligram per kg per minute. So a real high dextrose delivery there to maintain euglycemia. So we could actually collect critical samples quite fast for this baby. And what is your interpretation on those values there? In keeping with hyperinsulinism. So you suspect when it's above 10 mg per kg per minute of GIR, that's the case here. You diagnose when there is detectable hypoglycemia with plasma glucose less than 54, and that's the case here. And so by day 5, we have no doubt that this child has congenital hyperinsulinism. By day 6, we initiated the baby on diazoxide, but the GIR requirement didn't really come down. Over the next few days, we kept going up on the dose. We tapered and stopped hydrocort. We actually had to add on octreotide. You will remember that that's given as a subcutaneous injection 3 to 4 times a day. Even on high doses of octreotide, this baby continued to have hypoglycemia, and we went on to add nifedipine as well. So how does nifedipine act here? Okay, calcium channel blocker. But it didn't work even after acting nifedipine. So what do you think this is likely? What sort of do you think this is diazoxide responsive? Do you think it's diazoxide unresponsive? By day 24, we have diazoxide on board. We have octreotide on the highest dose. We have nifedipine, and our GIR is 20 mg per kg per minute, not off IV as yet. It is likely to be diazoxide unresponsive. So in diazoxide unresponsive, what is the predominant genetic mutation that you see? KCNJ11 and ABCC8. So potassium channel mutations. Actually, ABCC8 is more common than KCNJ11. So why do you think nifedipine didn't act? It is a potassium channel mutation. Why doesn't? So nifedipine should have acted, right? Theoretically. So it's believed that even in potassium channel mutations, the L-type calcium channels function differently. They may not function normally. So often or mostly what we see is diazoxide unresponsive forms, even nifedipine doesn't act. So as we suspected, we got one of the potassium channel mutations positive. It was a homozygous mutation on KCNJ11, which was again confirmed by our lab on Sanger sequencing. Parents were validated to be heterozygous. And how do you think would have been our phone call to genetic lab for this baby? At day 24, we are sitting at a small baby. Can you imagine having a 21 mg per kg per minute glucose delivery? Very difficult. Lines come out, prone for sepsis. Isn't it? Multiple phone calls a day for hypoglycemia. You're worried whether the baby will have brain damage. So there is a real sense of urgency here. And again, like Dr. Aaron highlighted, the rapidity to get that potassium channel mutation is really at a very, we are really wanting it fast. And thanks again to our team, we do get our results, authentic results, very fast. So here now, having confirmed this and, based on ACMG classification, this is to be likely pathogenic novel variant. What do we proceed? How do we proceed further? We know it's unresponsive. We know it's diffuse hyperinsulinism based on the DOTA TET scan that we did earlier. What do we do next? Baby is still on 20 mg per kg per minute GIR, still multiple hypos. You're still worried, oh, baby shouldn't have any brain damage. We need to do something before that. What do you do? Okay, that was done. That was diffuse pancreatic uptake. Sorry, I didn't highlight that. So, 100% pancreatectomy. Everybody in the audience, does anybody have a different opinion? Okay, so, there are many things you can do actually, but you're right. The first and foremost, what traditionally we think is the only option. It's a diffuse pancreas involvement. We know it's unresponsive to the currently available medical therapy. Yeah, definitely you need to think about pancreatectomy. But the problem is, one, it needs to be done at a center which is specialized. Two, if you do a near total or subtotal pancreatectomy, as it says here, 59% will end up having diabetes by early adolescence, and further studies also quote similar numbers. So unless it's a focal disease or the paternal KCNJ11 monoallelic type of form, focal pancreatectomy works very well. Otherwise, diffuse or a near total or subtotal pancreatectomy invariably results in significant morbidity later. So you are almost protecting the baby from the brain damage, but introducing another disease in later adolescence. So not ideal. So we went ahead and did a literature search. At that point, this was early 2016. And by 2014, we had a case series of 4 infants who had received sirolimus, which is an mTOR inhibitor from the UK, for whom it was started at around 2 to 3 months of age. And they reported a good outcome at 52 weeks with normoglycemia. There were no other case reports from any developing country. So this was the only thing we had. So we contacted the authors and we figured out a few finer details, because on one hand, you want to protect, not give surgery to this baby. On the other hand, you don't want to immunosuppress and child die out of a sepsis. So you really have to weigh out the pros and cons. So here we did finally initiate sirolimus, thanks to our patient's family, who were very, very opposed to the idea of surgery. We could easily start sirolimus for this family. We got their consent and started at very early, within a month of life. And by day 51, despite baby having had a sepsis in the interim, we could discharge the baby on lower doses of octreotide. With very intensive follow-up, we came off octreotide and the baby was maintained only on sirolimus therapy. So a diazoxide unresponsive form, we did try Siromus, and that did work for this baby. And to give more hope for pediatricians, physicians, endocrinologists from developing countries like ours, we also published our data when the baby had come to us at 14-month follow-up and was doing well. Now he is nearly 6 years old on very low doses of sirolimus, doing very well. I also want to introduce you to the fact that as much as you use in adults, a flash glucose monitoring system can be used in newborn as well. So you are aware that transmitter is there. There is a needle sensor which gets the interstitial fluid glucose assessed every few seconds and gives up a report every 5 to 10 minutes. You get the graphs and you can have a look at that and decide how your therapy is going. There is a worry about reliability at low values, which is a legitimate worry, but we can take hope from the fact that even on preterm babies less than 1200 grams, Lancet publication is there which proves that definitely you can pick up, and there is less severe hypoglycemia with real-time glucose monitoring. In our experience also, we would recommend, knowing that there can be a little bit of accuracy problem at low values, but we would still recommend over hourly or 2 hourly glucometric RBS checks for these babies with congenital hyperinsulinism. So just to summarize, you need to suspect and diagnose early because you want to avoid a baby with neurological disability in a child with congenital hyperinsulinism. Look for diazoxide responsiveness. Be good friends with your geneticists and get the genetic testing requested for early reporting. And you utilize FGMS even in newborn. Consider newer therapies. Sirolimus is there. There is lanreotide, which is a long-acting octreotide, which has also been described, not from India, but has been used in slightly older newborn, and recently also less than 6 months they have tried it abroad. There is also some people give octreotide using an insulin pump as a continuous infusion. So there are a few options available. There is also more research needed because there are also some conflicting reviews on partial response to sirolimus as well. So there is more to it than just considering your total pancreatectomy. Thank you.
Thank you, Sophie. In the interest of time, we will have one question, something that you'd like to ask.
Have you come across any perinatal stress-induced hyperinsulinism for a prolonged period?
Yes.
More than 3 months?
Yeah, true.
So usually we think of it as only you rightly brought it out. Usually we think, please sit. We only think of it as, it should settle down within 3 to 5 days, transient hyperinsulinism. But we have actually given diazoxide for up to 5 months for a baby also. So rarely, it's not the common presentation. Commonly it settles down within first few days, maybe 1 or 2 weeks. But rarely even up to 6 months has been described in literature as well.
Thank you, Sophie, for that absolutely lucid presentation and fantastic exposition, which I'm sure most of the adult and clinical community has kind of understood after what you said. Let's give Sophie a big hand, and not just Sophie. Presented, but I think I've made an excellent and devastating. So thank you so much again. And this is just a primer. I don't know if we can teach you the whole of genetic endocrinology in 2.5 hours. We've got 1 more hour to see the lab. But I think what people should be doing is to definitely get more into genetics. It's important for the future. It's going to make a big difference to the management of healthcare. Those of you who are generally interested on a long-term basis, please seriously think that once you finish your DM, you should work for 1 full year in a lab. That is what you really need. And if you're academically inclined, or if you want to make it part of your blended future, seriously think about that. I think it will make a very big difference.